our provider development program, and today we're going to be continuing our clinical reasoning videos, and we're moving on to part 3, which is cognitive errors and how to combat them. So as a reminder, here's where we've come from. So part 1 was mainly an introduction to clinical reasoning and why it's so important. And then we spent most of our time in our part 2 videos about how we think, learn, and apply knowledge as physicians and APPs. Today's going to be, or part 3 is going to be a 2 video part. And in the first half, we're going to be talking about cognitive errors, or common biases that result in cognitive errors, and when and how they introduce themselves. And then in the second half of part 3, we'll talk about how to combat them. And then part 4 is really getting down to the practical aspects of this series and learning how to put all this into practice and ultimately becoming a better diagnostician, becoming better at clinical reasoning and reducing your diagnostic error. So here are our objectives. We're going to recognize that cognitive errors are prevalent, complex, highly subjective, and extremely difficult to identify and analyze. We're going to become familiar with the different types of biases that exist and how they can influence clinical outcomes. And then we'll learn about different techniques on how to combat these biases and reduce cognitive error. Okay, so we're going to start off by reviewing the different types of biases that may influence our clinical decision making. So first up is affective bias. So this, in a nutshell, just says that emotions can influence thinking, and emotions can result in thinking errors. This is pretty obvious, but it's important to note that both positive and negative emotions can have impactful outcomes in our diagnostic abilities. For example, I experienced this my first year as an attending. I had a female patient in her early 30s who was dying from metastatic melanoma, and even though they didn't exactly look much alike, there was something about this patient that strongly reminded me of my wife. And so I remember getting a little too emotionally invested in her case, and I'm sure it influenced my decision making, especially when it came time to discuss goals of care. I'm sure we've all experienced similar situations. All right. Moving on to anchoring bias. So this is perhaps one of the most common mistakes, cognitive mistakes that we make. And that is when you have a narrow focus on a single feature in a patient's presentation to support a diagnostic hypothesis, even if other concurrent features refute this hypothesis. Okay, so a simplified example of this would be failing to diagnose a patient correctly with heart failure and incorrectly diagnosing them with something else like atypical pneumonia solely because their BNP was normal. Okay, so it's not a perfect example, but it kind of gives you a simplified idea of what anchoring bias represents. Okay, availability bias. Availability bias. This is the tendency to think that things that come to mind immediately are more likely or more common. Okay. Now, when I say more common, this is in the sense of how we were taught in medical school, such as thinking about a pheochromocytoma in any case with uncontrolled hypertension. We think about it all the time. It always comes to mind, but it's virtually never a pheo, right? But in a more practical sense, I see this with really busy clinicians, and especially when they're seeing high volumes of diseases that in fact are common. An example would be, during the height of the COVID pandemic, for us to think of COVID in a patient who presents with myalgias, malaise, dyspnea, fever, cough, and just assume that it's COVID initially, and failing to recognize maybe this patient actually has heart failure from bacterial endocarditis of the mitral valve. Okay, that's availability bias. Okay, blind obedience. So this is inappropriate deference to the recommendations of authority, either by direct superiors or expert consultants. Okay? And this can occur even in the absence of sound rationale. Now, this happens a lot with residents, but we hospitalists are guilty of this too. Now, of course, I think the teams that we consult are overwhelming overwhelmingly correct the majority of the time, but sometimes they'll make impractical or inappropriate recommendation, and we kind of know it. We kind of feel that twinge of doubt deep in the pits of our stomach, but we go along with their recommendation because, well, endocrine said so, or whoever. Okay. Now, and that's what we refer to as blind obedience. All right, confirmation bias. This is the tendency to search for evidence to support an initial diagnostic impression, and the tendency not to search for or even ignore evidence that refutes it. Okay, so this is really closely related to anchoring bias. The difference is that with anchoring bias, you are focusing on a feature of the presentation which leads to an incorrect diagnosis. Whereas with confirmation bias, you start with an incorrect diagnostic assumption or diagnostic hypothesis, and then you look for features that fit. Okay, so a good example of that would be, a patient who's been treated frequently for routine headaches in the ER, and the next time she comes in, she actually has a subarachnoid hemorrhage, but she gets an incorrect diagnosis of routine headache, and we have a bad outcome. Okay, so that's kind of the girl who cried wolf. Not a perfect example, but it gives you an idea of what confirmation bias is. Okay, diagnostic momentum. This is a big problem. So this is the tendency of a diagnostic label to become propagated by multiple intermediaries over time. Now, this can be propagated by anybody involved in the patient's care, the patient themselves, physicians, nurses, other team members, and what may have began as a working diagnosis ends up becoming a definitive diagnosis and gets thrown into every HPI down the road. Okay, we really struggle with this when it comes to psychiatric illnesses, as well as substance abuse disorders. Okay, framing effect. I'm guilty of this one a lot. This is the susceptibilities of a diagnostician to be disproportionately influenced by how a problem is described to them, or by whom it is described. Okay, so I think we commonly make this mistake when we're taking report from the ER, or when a resident is presenting a case to us, or maybe when a trusted colleague hands off their patients to us at the end of a stretch. Like I said, I've been guilty of this a lot, and it often, I may have some inclination that how the patient was previously framed might be incorrect, but it takes days of second guessing myself and mulling over where I may be wrong before I actually go down a different road because of how that trusted colleague handed the patient off to me. Okay, hindsight bias. So this is knowing the outcome of an event influences the perception and memory of what actually might have occurred. Okay, so we have to fight this one really hard when we discover errors that our colleagues have made. Okay, and we have to fight this in our clinical improvement conferences, our quality initiatives, our M&M conferences, and this is essentially saying hindsight is 20/20, and we have to recognize that things that are obvious to us in the future may not be obvious to the person who made the error in the moment. Okay, and hindsight bias leads to us not learning from mistakes like we should, and it leads to the potential for us to both underestimate and overestimate what was involved in the initial error, okay? And at the time the error occurred. Okay, overconfidence. So this is the tendency to think that one knows more than one does, especially in physicians who might place faith in opinions without gathering the necessary evidence. Now, this is not necessarily referring to hubris or cockiness. More so, overconfidence is one of the more commonly encountered biases in medical decision making, especially when patients are complex or uncertain. And the data shows that this most prominently occurs with ER physicians and hospitalists or internists because of the types of cases that we deal with, right? We have complex, acute, undifferentiated patients. And when patients present with these non-specific symptoms, we often go with our gut feeling, and we're overconfident with our gut feeling. And the data shows that that's often an unreliable way to reach a diagnosis. Okay, premature closure. So this is making a diagnosis before it has been fully verified. Okay, this is especially common when a patient presents with what could be an exacerbation of a known chronic disorder, and we fail to consider other diagnostic possibilities. We just attribute it to their CHF or their COPD. Okay. Now, we're not going to get into semantics, but technically all misdiagnoses are premature closures. But in a more narrow view, this here is what that bias is referring to. The problem that we need to recognize, though, is despite how I've just presented them, these biases don't occur in isolation. They occur together or simultaneously. And this is what makes it really hard to combat. Okay, so for example, say you're on an admitting shift and you get a phone call from the ER trying to admit a patient who they've told you has heart failure. And so now you could be a victim of the framing bias as well as diagnostic momentum. And now as a result of that confirmation bias, the physician may, or the admitting APP may only ask questions about heart failure symptoms. And they'll totally neglect questions about symptoms or risk factors or other diseases that might present similarly. Okay, so this biased cognition can have an effect throughout the entire patient encounter and often throughout the entire hospitalization. Okay, so this just goes to show that faulty data collection is not always due to poor execution of clinical skills, meaning you may ask the right questions at the right time, but you're asking them in too narrow of a fashion without seeing the whole picture because you've been biased in multiple ways. Okay, so as the biases previously described can exert effects anywhere within the diagnostic process. Okay, and this is a nice cartoon outlining the diagnostic process. So we collect data, we then organize that data, then we create problem representations, which we talked about in session 2, then we form a differential diagnosis. Again, we talked about that in session 2, and then we compare all those diagnoses to all the known illness scripts that we have within our mental repository. Okay, and as we're comparing them to our illness scripts, that's going to either drive us to collect more data and narrow our differential further, or we think that we have the data that we need and we're going to ultimately select a diagnosis. Okay, so now those clinicians with large repositories of illness scripts, like those who are really experienced clinicians, they might be more likely to arrive at the right diagnosis because the diagnosis is more likely to correspond with an illness script that they already have in their collection. Okay? However, those with more limited clinical experiences, their scripts may be too rigid or too narrow, or too narrowly defined, or even incorrect. And so they're less likely to arrive at the correct diagnosis, and they're more likely to be influenced by these biases. And then when you throw in more rare diseases or common diseases presenting in an unusual way, these present particular challenges for those with a limited number of illness scripts, and they're going to be heavily influenced by these biases and often arrive at an incorrect diagnosis. All right, so as I mentioned on the last slide, biases can influence us at any step along the diagnostic pathway. But situations can, or there are situations where biases can contribute to error that doesn't fall anywhere along the diagnostic process. They're external factors, so external to what's going on in our minds. There are other factors that can influence or that can introduce biases that influence our medical decision making. Okay, so this box here is a nice summary of the different external factors that can contribute to bias introduction. So handoffs, as we all know, are major problems. That can be a physician handing off patients at the end of a stretch. It can be a transfer of a patient from the ER to the floor or from the MICU to the floor. Time pressures are a huge problem. We know this, right? So we have a high patient volume. We have lots of distractions, interruptions, pages, vocera messages. We have loud working environments. individual physician factors play a role. So you can be the most astute clinician there is, but you may be fatigued or sleep deprived, or you may have some external personal stress. And all these things can influence our decision making. Team factors play a role. We talked about hierarchy and referring to experts or the attending when you're a resident. Specialty services make a difference too, or the type of service makes a difference, whether it's a specialty service or a generalist service. Groupthink can play a role. And then, of course, the patient factors can contribute significant biases. Maybe it's a difficult patient with a poor reputation. We're going to be likely to be guilty of countertransference or stereotyping. And these are all going to introduce biases to our diagnostic processes. And of course, these patients often tend to have the most complex illness as well, making us even more likely to make an error. Okay, so we're going to stop here, but really the take-home point at this transition point is that we're not going to be able to avoid all of these errors altogether, but there are different ways that we can maybe mitigate them and combat them, and so we can reduce our chances of having a cognitive error. And we'll talk about that in the second half of part 3. So see you then.